In this context, with all these available drugs and the landscape that you saw, what was evaluated was the bispecific antibodies. These act very, very differently. The bispecific antibodies have two targets. One is a BCMA, and this is the one that is expressed on the myeloma cells. The second one is the target is the CD3, or this is expressed on the T cells, the killer cells of the body. So what these bispecific antibodies are doing is to bind the BCMA and CD3, redirects the T cells to help with the lysis of the BCMA expressing myeloma cells. So very unique technology. There are several other bispecific antibodies that are under evaluation, but teclistamab is the one that is much more developed or more mature in terms of the efficacy and safety that was seen on the MajesTEC-1 study. So what MajesTEC-1 study did was to evaluate in two portions. So the first one is the part 1, which included 40 patients. The second part 2, has 3 cohorts: cohort A, cohort B, and cohort C. Cohort B and C were not included in this analysis, but cohort A is the only one that is included in this analysis. So altogether, we had 165 patients. And among these 165 patients that received teclistamab subcutaneously, 1.5 milligram per kilogram once weekly after the initial step-up dosing, these patients continue to receive these over a long run. So majority of these patients are continuing to receive these treatments and maintain those responses at the follow-up of 14 months that we have presented at ASCO today. So coming to a patient characteristics perspective, the patients were, median age was 64, and we were able to see that 15% of these patients are above the age of 75, and patients received a median of 5 prior lines of therapy, and almost everybody is triple class exposed, like how I talked about the 3 different classes, the first 3 different classes. And 70% of these patients are triple class refractory, and 30% are refractory to all the 5 classes that I talked about. So this is a heavily pre-treated patient population, and getting a response is difficult in this patient population. In this context, by giving the teclistamab, you're able to see an overall response rate of close to 64%. So in other words, 2 in 3 people responded. And when they responded, they had much deeper responses. The VGPR rates were close to 58%, and the CR rates are close to 40%. More importantly, the depth of response as measured by MRD negativity, which is minimal residual disease negativity at a threshold of 10 to the power of -5, these were seen in a quarter of the patients. We look specifically at that cohort of patients who achieved a CR. These MRD negative rates are 50% of the CR rates. So from an efficacy perspective, we always look at what is the median progression-free survival. It is 11.4 months. And this is almost equivalent to the CAR-T cohort from the ide-cel that we talked about earlier. And this ide-cel was approved by FDA last year. And this ide-cel at the cohort dosing of 450 million CAR-T cells had a PFS of 11.5 months. So this, without going through the CAR-T cell manufacturing process, the lymphodepletion, we are still able to get the benefit, the similar kinds of benefit by using this bispecific antibodies, which are off the shelf. And if I want to give it tomorrow, those are available off the shelf, so once approved. So that's the benefit about the response rates. Now looking at, there's always, you have to balance out the toxicities. Are the toxicities prohibitive enough that you cannot give these drugs? The answer is no. These toxicities that we deal with compounds like this are the main ones, the CRS, or the cytokine release syndrome. And when we look at the incidence of cytokine release syndrome with this specific drug, it was seen in 70% of the patients, but grade 2 was seen in only 30%. And patients received tocilizumab, which is an IL-6 antagonist for these patients. And all these CRS started to resolve, and there are no dose discontinuations, no dose reductions because of CRS. So now, looking at the other toxicity that we typically see with classes of the bispecific antibodies like this are the neurotoxicities. And the neurotoxicity in this setting, it's again grade 1, and they were seen in less than 15% of the patients. And these are all resolved by themselves. There is one case which is a grade 4, but that happened in the context of the patient with bacterial meningitis, but that resolved very quickly as well. So other side effects that need a mention are there is an infectious signal. These are given for a longer period of time. They're following the protocol, and there is hypogammaglobulinemia and neutropenia that led to the increased risk of infections. This is again, the study is done in the midst of a pandemic. There were 12 COVID-related deaths in this whole cohort. The patients have recovered. Most of the patients have recovered, even if they got COVID. But again, from my opinion, the infection signal is real. We need to have proactive prophylaxis of what can be done to prevent those infections. Could this be spacing the drug? Could it be finding the alternating dosing schedules? Or could it be providing the antibiotic prophylaxis, antiviral prophylaxis, all those to prevent that risk of infections? This is a bispecific antibody that can be given as an outpatient in the community. So the only requirement for this drug to be given safely at this time is, given the risk of the CRS or the cytokine release syndrome, so we require hospitalization for the priming dose and the first dose. And this, I believe, at this point of time, until people get a handle of how to give this drug properly, it probably may need to be done in an academic setting. And once these resolve over time, within weeks, from the second cycle onwards, it can be given in the community. And this is the advantage. You're able to get the benefit of what a CAR T cell therapy gives, yet this drug can be given in the community. To summarize, this is a very well manageable drug, and I feel very comfortable giving the drug, and we can deal with the toxicities. We can easily understand the next steps of how to work on the toxicities to minimize the toxicities, maximize the benefit.